as wild-type adult myocytes treated by cyclosporine A or treated by postconditioning, for example. And the group of Derek Yellen in London showed that cyclophilin D knockout mice, as reported before, have a spontaneous smaller infarct size when compared to wild type, but they also cannot be protected by postconditioning, which suggests that postconditioning is acting through pore opening or through cyclophilin D modification. Based on this, we wanted once again to come back to clinical practice. So we said that if cyclosporine A is able to protect the heart in mammalian models, in the rabbit, in the mouse, why don't try this drug in clinical situation? So we performed a second proof of concept study in which we randomized acute myocardial infarction patients into two groups, a placebo group that received saline and the treated group that received cyclosporine A. And we injected cyclosporine A in the brachial vein as an IV bolus at a dose of 2.5 milligram per K before reopening the artery. And then let the reperfusion go on and measure infarct size by two means, cardiac enzyme release and MRI. You show that this is a small number of patients. This is a proof of concept study, but the two groups of patients are very comparable regarding usual comorbidities, LV and geography characteristics, ischemia time, treatments, etc., etc. So the two groups are comparable with respect to usual characteristics. And what we showed that is depicted here. If you consider the cardiac enzyme release or the troponin I release, which are surrogate endpoints for infarct size, patients that receive cyclosporine A developed smaller infarct when compared to controls. This is the usual representation as shown before. You can see that patients that receive cyclosporine A, especially patients with large area at risk, develop smaller infarct when compared to the control patient. In other words, cyclosporine A is an example that you can alleviate, attenuate reperfusion injury by a drug given in a timely manner at the time of reperfusion. This, we confirm that this was also true by when you measure infarct size by MRI, which is the white area air. We had a 28% reduction in infarct size by MRI. Now we want to, in another study, we wanted to check whether this early positive effect was also true 6 months later. And we performed, we see again this patient in the hospital 6 months later and measure infarct size by MRI and still found this reduction in MRI. And we also saw that there was a trend toward an improvement in LV dilatation as measured by MRI. We had a reduction in end diastolic volume and end systolic volume, whereas we had no impact, and this was expected, on LV hypertrophy by using cyclosporine A. Now we want to go further. We need in this field of research to go beyond the proof of concept study, and we are in the process of building a larger study to see whether giving cyclosporine A not only reduce infarct size but improve outcome in patients. And in February, in two or three months, we will start a multi-center trial in which we will have the very similar design giving cyclosporine A or placebo to patients, but this time we will look at hard endpoints. There is a cumulative endpoint of death, hospitalization for heart failure, and LV remodeling. And we expect to include a huge number of patients to finally determine whether cyclosporine A that reduces infarct size also improve outcome in these patients. And I would like now to finish to share with you new information we have extracted from these last 5 years studies with respect to postconditioning. The first, and this is interesting if you want to design new study in the future, it's methodological aspect and aspect regarding comorbidities of patients. The first thing that is obvious is that if you have to exclude patients with coronary collaterals. As shown here, you have infarct size as a function of area at risk as usual, and I plotted in this slide only control patients in black are patients without visible collaterals, whereas in the empty square here, you have patients with visible collaterals at the time of admission. And you can see that these patients are spontaneously protected. If you have collaterals, you have a 60% reduction in infarct size. What does that mean? It means that if you include this patient in the trial, you will dilute the data. And if these patients are in the control group, they have a spontaneously reduced infarct size, and they will decrease the statistical power of your trial. So you have definitely to exclude these patients from any trial where you want to see an infarct size reduction. The second aspect, which is the most important, is that, as I said before, area at risk here, ACS, is a major determinant of infarct size. If you look at the control group in black, you have a correlation with infarct size and area at risk. And you can see that the post-conditioned patient, the empty squares, are usually below this regression line. But the most important is that the beneficial effect is much more important. The reduction in infarct size is much more important for patients with large area at risk. And if you have sort of a cutoff of 35% area at risk, if you have a small area at risk here, you only have an infarct size reduction by less than 20% in this type of patient. Whereas the major benefit is for patients with large area at risk. And this is also probably an important aspect if you want to select patients for trials aimed at reducing infarct size. And if this is another way to present this data, please consider what is written here. Let's say 80% of patients with an LAD occlusion have an area at risk more than 35%, whereas only 20% of patients with right coronary artery occlusion have an area at risk over 35%. What does that mean? It means that if you want to design a trial for testing a drug or any intervention that reduces infarct size, you have to choose LAD patient occlusion and sort of maybe not take into account patients with right coronary artery occlusion. How to assess area at risk in clinical practice? You have several ways of doing it: SPECT imaging, MRI with T2-weighted sequences, LV angiography, or a very simple and old method called the Barry score, which is a giving index to with respect to where the occlusion is on the coronary artery tree. This is difficult to do before reperfusion. It's even impossible to do before reperfusion. This is very difficult. This is feasible. We have preliminary data showing that using the Barry score, the coronary angiography score, is quite well correlated with the LV angiogram we do. And this is available for any clinical trial. So I would strongly recommend for any people doing a clinical trial to at least use this way of measuring area at risk. Using MRI to measure area at risk, to me, is a concern. David, years ago, showed that T2-weighted sequences can very nicely depict the edema that is formed during ischemia, but mainly during reperfusion. And T2-weighted MRI imaging is a very nice way of showing myocardial edema after reperfusion. And it even showed that this is well correlated with measurement of edema by pathology. My concern is that we have problems publishing a paper in the pig model showing that this is, to us, not a very good way to assess area at risk in the experimental setting. In the y-axis, in the 4 panels, you have infarct size measured by the reference technique called TTC staining. If you plot infarct size versus area at risk measured by different techniques, you end up with this regression. Here is area at risk measured by a blue dye technique in animal models, and this is very nicely corrected as expected. If you measure area at risk by scanner and DCT, the correlation is fair. But if you measure area at risk by T2 weighted imaging in two different sequences, the correlation is fair, but you see that it is shifted on the right. Simply, it is overestimating the area at risk as shown here. And this is definitely a problem that should be avoided in clinical settings. We can ask several questions in clinical practice, and PCI cardiologists now are using a lot of new technique, including one which is called thromboaspiration. That is, before they do the angioplasty and the stenting, they try to withdraw the thrombus by different techniques. And of course, this is done at the time of reperfusion. So one may question whether this by itself can reduce infarct size, and another question, whether by itself this will delay the application of postconditioning and prevent the beneficial effect of postconditioning. So we looked at this, and here are in the control patient, in black, the patient without thromboaspiration, and in white, patient with thromboaspiration. And you can see that there is no difference between the two groups, indicating that thromboaspiration does not reduce infarct size per se, which is good news to me. The second aspect is, does thromboaspiration prevent postconditioning? Here is a regression line for the control group, but looked, the triangles are patients without postconditioned patient without thromboaspiration, whereas the empty squares are patients with postconditioning plus thromboaspiration. And there is no difference between the two groups. In other words, thromboaspiration is not preventing by any means the beneficial impact of postconditioning. So this is also good news for protecting reperfusion, for the efficacy of postconditioning in these conditions. And last but not least, I would mention the influence of the duration of ischemia on the efficacy of postconditioning in patients. We divided the patients that have been included in our several trials over the years into two groups: patients that came to the hospital after more than 3 hours of ischemia versus patients that came after less than 3 hours of ischemia. If you look at patients that come after 3 hours of ischemia, we find the usual reduction of infarct size between control and postconditioned groups, and this is very significant. But, and this is a bad surprise, if patients come to the hospital less than 3 hours after the onset of symptoms, they are not protected by postconditioning. You can see, by the way, that control versus control, there is a reduction simply because the duration of ischemia is less. But in these patients that are patients with low or small infarct size spontaneously because they have a small amount of duration of ischemia, postconditioning is not adding any benefit. And this is, by the way, the exact replication of what the group of Maninveld in the Netherlands found in the rat model. So maybe in the future we should carefully look at this aspect, that is the duration of ischemia, to include patients in postconditioning trials. So to conclude, I would say that from this translational experience, there is now strong evidence that angioplasty postconditioning can reduce infarct size in acute myocardial infarction, that in the future we ought to measure the determinant of infarct size, including area at risk, to test new treatments for infarct size reduction, and that we have new pharmacologic agents that are able to be tested in these appropriate conditions to prevent the detrimental effect of large infarct in our patients. Thank you for